So one of the challenges is that our immune system is very active, but a little dumb. All right, so what can happen is that our body will react to an infection, but actually what it might be doing is attacking itself. Okay, so I'm going to go through some real specific examples of how this might occur. But I think we all in our society have a bit of a sense of this. So we know that strep, we've known this for 200 years, that strep infections in childhood can cause something called Sydenham's chorea. And you get a strep infection, and usually within 24, 40 hours, these children would develop movement disorders. And I'm going to show you some videos of what those movements look like. So we have known this for a long time. The other very classic corollary, I think, with these conditions that we're talking about is rheumatic fever. So rheumatic fever, again, it's a strep infection. You get a strep throat, and after that, your body makes antibodies against the strep, and those antibodies happen to also be able to attach to your heart valves, and that's rheumatic fever. So you probably have heard that there is some controversy about this condition. I'm not quite sure why, because we have lots of history of understanding this rheumatic fever and Sydenham's chorea for hundreds of years, and this really isn't that different than those conditions. We also know that if you've had a sense, I don't know if you've looked at this in the world, but these conditions are more common than they used to be. All right, so I was downstairs looking at the food, and there's a huge area that's of gluten-free sandwiches, right? So some people are just gluten sensitive, but celiac disease is actually a lot more common. This is real. I saw a study recently where they had saved the syrup from military recruits in World War II. And they ran celiac panels on all of them. They found almost no celiac disease, which is a huge shift in our culture and actually across the world. Autoimmune diseases are more common than they used to be. Okay. Next. Okay. So this is an example. This is again kind to reinforce that these conditions, rheumatic fever and Sydenham's chorea, which I think are very similar pathophysiologically to the condition that I'm going to describe, have been around for hundreds of years. This is an old textbook from 200 years ago showing what Sydenham's chorea, the movements of Sydenham's chorea, what they look like. Okay. We also have a lot of epidemiologic studies showing that after strep, so these are neurotypical kids that after strep, they were 3 times as likely to have movement problems. These were usually tics. 2 times as likely to have more behavior problems. And the more strep infections that you had, the more likely you were to have these issues. And then again, with OCD and tics, Denmark is great because they have a national health system, and you can pull all kinds of really good data. And so what they saw was a marked, look at that, 51% increase in OCD with presumed strep. It's really remarkable compared to 28% in the non-strep group. Okay. So this is where you get into my immunologist friend. So
that's so cute.
So it's interesting. What is the actual underlying pathophysiology of this condition? One is, and I'm going to go into more detail of this, is that your body is confused. You make antibodies to the strep, which is natural. You get a strep throat, you make antibodies, but those antibodies actually attack your brain. because the blood-brain barrier is disrupted. Now, why is it disrupted? That's actually a key area of research. Why is our blood-brain barrier leaky? Why can't we keep those antibodies out? And then, is there just an autoantibody? So is it your body continues to make those antibodies to attack your brain? We have seen, there have been actually a couple of reports where children have been diagnosed and then right after that they had an MRI, and what you see is inflammation of the basal ganglia. On PET scans, it's a little bit easier to see that because it looks at metabolism, and we see changes again in the basal ganglia. I also see that in Tourette syndrome. Yeah?
Would you also see that in a SPECT scan of the brain with like multiple heads, high quality SPECT scan? Would you see that too?
We don't know. Because it seems to be that if it's early and right after it, you probably would. If it is, this happened, this infection or this change happened a year or two ago, you might not. So it's hard to know. In general, MRIs, if you wait a couple of months, MRIs are normal. Yeah.
Is there a super sensitive strep test that can see if you have it floating around in your system or hiding in your system, besides the basic strep swab that they do in the pediatricians?
If you had it in your bloodstream, so that's a great, so first of all, we culture more than just the throat, looking for it, because a lot of kids have it perianally. So we'll do an anal culture as well. If it's not going to be just floating around, because if you have it in your blood, you are probably going into shock and really, really sick. So no, not as far as a blood test, but we do culture other areas.
Okay.
Interestingly, and this is, at the end I will talk about some of the research projects we have going on, but if you give a strep infection to a rat, you can actually induce these changes in rats so that it's clear that this is can be repeated in a lab with rats. And also, you don't have to just give them the strep. We can give them the IgG that is specific to the strep and get the same condition, the same inflammation of the basal ganglia and the same movement parts. So it's interesting to see rats with chorea and tics. I hadn't seen that before. Okay, the next one. Okay, so just where are your basal ganglia? It's in the middle part of your brain. The basal ganglia are the part of your brain that are associated with movement. So in order to, if I want to reach something that I have a smooth movement wherever I'm reaching, it's the coordination of the basal ganglia that allows that to happen. We also see obsessions, compulsions, OCD also lives in that part of our brain. So it actually makes a lot of sense that this is the part of the brain that is inflamed in this condition. Next. All right. So this is a challenging condition, and I'll show you our whole team of people. This is not something that I would recommend one doctor try to treat because you've got so many moving parts to it. So think about yourself. You have a child who may be neurotypical, may have autism, may have ADHD, may have asthma, whatever it is that they have. But in 24 hours, they wake up and they are a completely different person. This is a life-changing, extremely stressful thing for families to go through. And we see families absolutely falling apart. It is it's terrifying. And then if you go and people don't believe you, which we see a lot, then it's even more stressful because your reality is not being acknowledged. There are certain neurological conditions such as tics and chorea that are not infection related. If you go to any kindergarten probably through second grade classroom and just watch, 10 to 15% of those kids have tics. Normal. And they are going to outgrow them as their body matures and their neurological system matures. They just go away over a couple of years. So this is something else. This is not this. Then we have genetics. which is you are predisposed to having OCD, predisposed to having other conditions. And you grew up in a family where everybody has anxiety, where everybody has whatever it is that we're concerned about. Idiopathic, some people have have OCD. That's part of who they are. And it is not related to an infection. And then you have this change. So our challenge is, and that's why we have all these people working on this, is that we need to deal with all of this at the same time. And it's complicated. So what we end up doing is putting together a treatment plan that addresses all of this. So that when we're moving forward with this plan, we're not just treating this, we also have to manage each of these different areas. All right, so this is the details of the diagnosis. This is a condition which is an overnight change with OCD and severely restricted food intake. And the restricted food intake is, maybe it's a little bit, it's not sensory, it's not body image. But these kids stop eating. And they, what we see, if they're able to communicate what's going on, what they typically tell us is that they're afraid their food is going to kill them. Right? They're afraid they're going to choke, or they're afraid that their food is contaminated, so it's more OCD. And so they will absolutely stop eating. And then, so this is the criteria right now. These are consensus criteria, so we're really working hard to try to piece together. And we'll get this diagnosis and these diagnostic criteria, I will bet will change over the next few years as we learn more, and we'll hone it down a little bit better. But for now, this is what we got. And so we need at least 2 of these other ones, which is anxiety, really severe anxiety. Sometimes we see generalized anxiety, but I will tell you what we most frequently see is severe separation anxiety, where a child cannot leave one person. And it's typically mother, but it can be somebody else that they're attached. They've got to have I see children who they will not leave their mother's side. She's in the bathroom, she's in the shower, and that child is right there. Emotional lability and depression makes sense. Irritability, aggression. So this is, I think, when the children in our clinic who we see who have autism, if they have ABA, all of a sudden their data goes wacky because they've got a lot more behaviors. Behavioral and developmental regression. Probably in that one, the most frequent one that I see is loss of language skills, loss of communication ability. Deterioration in school performance. A lot of times what kids will describe is that they just, and what parents describe, is the kids say, my brain just feels foggy, I can't focus. And the parents say, a really marked decline in memory. They'll ask them to do something, and 2 minutes later they have no recollection of what that conversation was. What's interesting with that, as we treat children, and then I see them a month or 2 later and they're better, they actually don't remember being sick, which is also quite striking. And their parents are, of course, have post-traumatic stress, and these kids have they're just like, oh, life is good. Sensory and motor abnormalities, tics and chorea, which I'll show you. And then issues with sleep, enuresis, bedwetting, or having urinary access during the day, and urinary frequency. And we really do a lot to try to separate out, is this Sydenham's chorea, which is different? Is this Tourette syndrome? And it's just Tourette syndrome. So we work really hard to try to clarify this is a diagnosis, they call it a diagnosis of exclusion. So we got to make sure everything else is not this. Working in this clinic is amazing, and I have learned to, when I go in a room, to not I'm very cautious not to touch children because frequently they don't want to be touched. I ask permission to do absolutely everything because they often have very severe contamination fears. So this girl that I saw recently, if anyone touches her, she immediately takes off her clothes and she has matches with her and she burns her clothes. What's that?
So take the matches away.
Yeah, 10-year-old boy can't tolerate staying in the exam. So during the clinic, we actually often end up seeing kids in different areas that we'll kind of say, well, what part of this place do you feel comfortable in? And we'll see you there. Then we have a 6-year-old girl who was obsessed that there were germs in her food, and this is an NG tube. We probably had 10 or 12 kids who were their eating restriction was so severe that we had to hospitalize and put an NG tube in order to feed them. And then again, the issues with children being absolutely terrified that they're going to choke on that food, and so they just refuse to eat. So I'm going to go through. This is will be some videos of examples of things that we see, tics in Korea. One of the challenges that I find is that, these are not, people talk about tics all the time, but in general in the community when we're talking about people say, I have tics, in general it's a habit. So you have to distinguish a tic from a habit. And I'll show you that. I'll show you what Korea looks like. One of the striking things that we see in the kids who are school age is a loss of handwriting skills. I'll give you an example of that. Okay. This is a video. If you click on it should be down here somewhere, there'll be something. Is that a video? Yeah, it's a video. Here, let me try.
Can you tell me about Mardi Gras? Yeah. You marched? Did you have a Mardi Gras parade? And what happened?
To the shoulders.
You did? And what happens at Mardi Gras? You did? How did that make you feel? Why? Do you want to put your mask on for me right now?
I don't have a stick.
Oh, did you leave that at school?
You can go to the next one. So that's a motor tic. There. Go ahead.
I have a question.
Yeah.
Did that tic on this little boy begin when he was addressed and asked to respond to something? Or was this noted before he was asked to respond when he was simply playing or eating?
This particular boy had them kind of all the time. But you will see when children have motor tics, particularly if they're aware of them, he's pretty clueless. But a lot of times children, when they are aware of them, you can control them or dampen them while you're in school. So if kids are aware, they'll control it, and then when they come home, when they're relaxed and parents don't care, they'll tic a lot more. So it will fluctuate through the day, often based on the awareness of the child. All right, can you make that one go? Oh, back. Now these are vocal tics, or phonic tics. Phonic tics are probably the one that people don't recognize, because another very common phonic tic is throat clearing. Throat clearing is also a phonic tic, and sniffing. And so people think that a child's allergies are getting worse when it's actually a tic. Go ahead and go to the next one. Try to run. It's a touchy computer. See the waving fingers? She has, this is really bad. She's not even able to keep her arms straight, but what we frequently see is the waving fingers. This is Korea.
Turkey.
Okay. All right. So typically this is bad, and so when we actually now we're starting to use a neurological physical exam that grades how bad the chorea is, and when you can't keep your arms, so we call that pronator drift. She's kind of doing this. That's much worse than just this, but I think the most common thing we see is just the finger waving. They call it piano playing. It's a Chinese vaguely playing piano. Okay. Yeah, try the next one. There you go. Okay. Handwriting. This is a young lady who, this is a homework. This is a child who was diagnosed with pandas and was treated and was doing fantastic. Was in school, and then go to the next one. Overnight, this is what happened to her handwriting. And then go to the next one because I have them side by side. Same child, 24 hours apart.
What happened?
She gets Strep. This is another neurological exam or part of our neurological exam that we look for, and it's part of chorea. It's another thing. So, but if you go to a neurologist and they ask you to hold the fingers like this, what they're looking for is it is milkmaid. It feels like somebody is trying to milk your fingers. So let's see if that video goes.
The patient with chorea tends to hyperpronate the upper limbs when attempting to maintain extended posture. The motoric resistance in chorea manifests as milkmaid's grip, in which the child relaxes his grip of the non, as if he is milking a cow. This is a case of sit-and-hands chorea in rheumatic fever. It is common in girls. Onset is common in 5 to 15 years and is self-limiting in weeks to months.
Man, we have to go to that festival tonight.
Okay, next one. The other thing that we frequently see by history, and then we often see in clinic because kids have to keep leaving, is that they just feel like they have to go to the bathroom all the time. They don't have a urinary tract infection, their bladder is not actually full. They go, they pee a little bit, and then they come back, and they are in the bathroom every 15 to 20 minutes. And then it's really for some kids, they've been toilet trained for years and years and years, and all of a sudden they start having accidents again. And if they're aware of that, that's really traumatizing for them. I mean, it's embarrassing. So they start having bedwetting. Yeah.
Is it, they must go relieve, or is it ever like a fidgeting, like just always, because they'll be like, get to the bathroom, yeah. But it's always like, you know, tough.
They describe the sensation that they need to go, but what we work on is trying to, and this is some of the behavioral stuff, is trying to get them to stretch a little bit because they don't actually need to. I've talked with some neurologists who do work with Parkinson's, and they find the same thing. And Parkinson's is a condition of the basal ganglia, so it actually just makes sense that this is part of the biological mechanism. So it's a sensation. Sleep issues, and this is actually really interesting. So we are working with, I think now there's 15 or 18 different universities and sites across the country. And one of the fascinating things when we got involved in this, we've been doing this for about 2.5 years. When we first started, we were, getting support and education from, it was mostly East Coast sites. And what they described a lot is very, very intense sleep issues. Kids just couldn't sleep, couldn't fall asleep, couldn't stay asleep, they were just up. We, at least so, and then on the West Coast, it's us and Stanford are the two sites that are active on this side of the country, and we're not seeing as much of that. We're seeing separation anxiety. I won't go to sleep because I won't leave my mother. not being able to sleep. And one of the things we've hypothesized, this whole group, the 15 universities, we get on a phone call, as many of us as we can every month, and we talk. And one of the things we brought this up, and one of the things we talked about is this a difference in the type of strep, the subspecies of strep on the East Coast versus the West Coast? I don't know. Yeah.
Do you see cases of hypersomnolence?
When the kids are really, really ill, we've seen about 400 patients in our clinic so far. Probably 2 or 3 times, I've seen kids who are so impacted by this condition that they're not communicating, they're not really engaged with their surroundings at all, and that they just sort of seem to fade from sort of sleeping to vaguely being awake. It's awful. So not just sleeping in typical. When we see that sleep, what we think is just kind of laying in bed, it's a really, really severe situation. Okay. So this is every single day, right now in this room, you are being bombarded by all kinds of things. Infections, okay? We're sneezing on each other, we're touching each other's hands, your system is being bombarded, and our body is asked to put up a fight against that. Okay, this is, and one of the interesting things about all of this is that our immune systems haven't changed so much as we've changed. All right, I don't know if some of the older people in the room, we were exposed to more infections. We probably some of us lived in rural areas where animals were everywhere. You were working outside, and now, what do we have? Antibacterial soaps and hand wash, right? Okay, we are very, very clean, too clean. And so our autoimmune systems, our immune systems are bored. When something is bored, it gets in trouble. Okay? So this is one of the things is when we talk, when you look up this theory, it's called the Hygiene Hypothesis. This is a reason to let kids get dirty, make a mess. Do not over-clean your house. Do not over-seal your house. A little dirt is really good for us. I say that a lot because I really hate cleaning. But just come to my house. Yeah. All right, go ahead. So what we want is that whatever it is, if it's a fungus that you're being exposed to, a virus, a bacteria, whatever it is, your body needs to make a key that fits that lock. Okay, that's the job. Go ahead. However, there are only 100,000 different, it's a regular key. This is interesting, this is in the key lock. There are only 100,000 keys that can be made, physical keys. So your key to your house fits somebody else's house. Your challenge is to find that house. Okay? But if we've got a million different possible car keys, these are all the different antibodies that we can have, and at some point there's going to be overlap. Your body's going to make a mistake, and that instead of attacking the strep, it's going to attack something else. And that is the underlying pathophysiology of this condition. Sometimes one key fits 2 locks or 5 locks or whatever it is. Okay? So this is where we get into moving towards treatments. Is how do we control this process where there's a mismatch? So we have an option, we can treat the infection with antibiotics, get rid of the infection, and then there's no need for your body to fight the infection, right? You don't need to make antibodies if there's no infection there. You can actually block the antibodies. Or we can suppress the immune system so your immune system just settles down and doesn't make antibody at all. Those are really our options for this condition. So So why is this is really hard? Why is it so hard? It's that the bacteria or viruses, or because some of this is a virus, so it's very clear that influenza and Coxsackie virus are associated with PANS. So this is everywhere. We're going into flu season.
What about HHV6?
Yes, as well. And you cannot avoid this unless you're going to lock yourself in your house. You're going to know people who get influenza this year. Okay. So, and whatever the infection is, then you can have that mismatch so that your key fits two locks. Now, our antibodies, so one of the things, and I don't actually go into this much, but I'll tell you, a lot of times people come to us and they have antibody titers to strep. Doesn't help us, okay? Because if you have a strep infection right now, your antibody titers are going to go up. And then naturally, over months and months and months, they're going to fade away. The next time you get a strep infection, they're going to go up. So if you have elevated antibody titers, you had strep. I can't tell you when. I can't tell you how many times. We find antibody titers helpful over time to monitor your body's response to infection. But a single antibody titer is worthless to us. And each of us have a different antibody decay pattern. So you start at 600 and you go to 300 in 3 months. I might go to 300 in a year. So it's different by person. What we have seen is, so we started, when we first started this clinic, most of the children who we saw were teenagers who likely had this occur 5 to 7 years ago. And by the time we see them now, there's not a lot we can do. The damage is done. We're trying, but they are not making great progress. On the other hand, we have seen quite a few children who are seen, diagnosed, recognized, treated, and are absolutely cured. So I'm a developmental pediatrician. My entire work life has been autism. And yes, we do a lot. There are a lot of things that we can do, both biologically and behaviorally and everything, to make things better. But I don't know that I've ever cured anyone. In this condition, I have absolutely cured people. So it's odd for me. Okay, go ahead. So what do we do? We have to address all areas of this condition. So we treat the underlying inflammation, we treat whatever the infection is, but then we also have to treat behaviorally. We have to provide family support. There's lots of pieces to this. It's absolutely not a quick fix. This is a really complex condition that requires a lot of effort to manage. One of the things that we try very, very hard is we obtain a lot of data. When families come to us, they initially go through a screening process. They tell us the story, and if the story doesn't match, we send them some. We don't see them. We have them fill out 6 different screening tools, looking at all the different. And that's a lot of work for people, but it really does help us because we look at. It helps us focus what we're going to look at. So we have an OCD scale, anxiety, ADHD, depression, Tics scale. We have all these different scales that we look at. And then if we're going to, and I'm going to show you the lower end interventions first. If we get to big guns, as far as intervention, we actually send them for neuropsych testing to do a full battery of cognitive and psychometric evaluations so that we can make sure that we know if there's a change. Now, how did we get there? We got there because the big gun intervention is IVIG. IVIG costs $40,000 for 1 infusion. And you can imagine trying to get an insurance company to pay for that. So what we have done over the last 2 years is we I think we know all of the medical directors in Arizona on a first name basis. But what we have done is is made a promise to them that we will get all of this data, we will do the testing, usually we do 1 or 2 infusions a month apart, and then we do the testing again, and if there's no change, we stop. And in general, that's the way that we get the medications and the drugs that we need. All right. So what do we do? The broad theory of this is to reduce inflammation. Again, as I said before, if there's an infection, we treat that infection. So if there's an infection, we treat the infection, and that's our first line. If there's no infection, we try not to use antibiotics. Okay? Because then that's just going to lead to resistance, and whenever you've taken antibiotics, I'm sure you've had the experience of having gut issues and all kinds of problems. So antibiotics are challenging. So we use them if they're indicated. Then we use, and we don't if they're not. Non-steroidals, ibuprofen and naproxen, which are remarkable. For a lot of kids, that's all we do. We can cure them with naproxen. So the reason I have both of them, we try to use naproxen or naproxen, which is Aleve, because it's longer acting. It's a duration of about 12 hours. You've probably seen on the television commercials. It does last longer. Ibuprofen is about 6 hours. So what we see with kids is if they can tolerate the naproxen, what we are seeing is that kids have a little bit more gut issues, more stomach pain, and things like that with the naproxen. So sometimes, and in ibuprofen, there are more different formulations. So you can get chewables and liquid suspension in multiple different flavors and all kinds of things. So ibuprofen is easier to give, but doesn't last as long. And so if those are working, what we tend to see with kids who are taking ibuprofen is that if they take it in the morning, by about 1 or 2, their symptoms are coming back because the ibuprofen is wearing off. And at that point, we'll tell a lot of families, do it 3 times a day if that's what works for you. But dosing something 3 times a day is very, very hard to do consistently. Yeah.
For how long do your clinic patients seem to need to take their Aleve or their ibuprofen in order to see, a home-based change in their presentation?
So, in general, with Aleve, with the non-steroidals, if they work, we usually see kids better in a week. And then the next thing is having to try to figure out how long are we going to keep them on this, which is another whole other discussion. If those first 2 don't work, we go to prednisone, which is oral, and we use a very short burst. So if anybody, if you or anybody you know has had significant asthma, it's usually a 5-day burst of prednisone. We use the same dosing. So it's pretty easy. So most pediatricians, who are the ones generally who we try to get to treat this, they're very familiar with how to dose that. We have seen 2 things. One is sometimes we will see kids, and if you've ever taken prednisone can make you just feel a little irritable, a little fidgety, and so we'll see kids have some behavioral things exacerbate for a couple of days, and then they get a lot better. The other thing we see is that there seems to be a group of kids who, yes, they respond to the prednisone, but as soon as we stop it, they seem to flare back up. And so we are probably following, I guess, 10 or 12 kids that when they need this, instead of doing a burst, we do a short burst about 3 days, and then we do a taper for about 10, 14 days. And so we let them down a little more slowly, and they do great. Then if we fail all of that, that's when we get to IVIG. So when you receive IVIG, you are receiving the immune system of at least 10,000, probably 40,000 people. That's remarkable. And so what that is doing is, so you're getting whatever immune response to, if you donate blood and your blood actually ends up in immune globulin, you are donating your history of infections to that person. So you have antibodies in IVIG to pretty much everything, and it dampens down the immune system. That's how it works. Yeah.
So once they have the strep, let's say they diagnose the strep, do we have to like straight away set up like a team in place, or wait until the symptoms happen?
Right, wait until the symptoms happen. And so, because for a lot of people, we don't all do this, right? This just happens to a subpopulation of pre-pubertal children. Once your kids have hit puberty, you're really not very at risk for this. And the other thing that we see is that the children who we do see, the symptoms, you stop getting as many flares, and the condition seems to burn out as you move through puberty. All right? He's good. He's through puberty. So, for this condition, puberty is really something to look forward to. It's a good thing. I know that's not, most of us, we're worried about puberty. But for this is great. Then the way, I've talked with our immunologist, like, why is that? And the way he describes it, which is not very scientific, is that when we are children, our immune system is not as mature, not as knowledgeable, and tends to be very twitchy, so it overreacts. And as we move into adulthood, our immune system has seen more things and started to recognize, okay, this is what I do when I have strep, this is what I do when I have the flu, and it doesn't overreact as much. So your immune system settles down in adulthood.
What about plasmaphoresis?
Yeah. So plasmaphoresis, which is actually taking your blood out, spraining, pulling out antibodies, putting it back in, we don't do it. And the reason we don't do it is, and some places do. If you want information on that, I can give you names of people across the country who do. However, it is, you have to put in a big line, usually one that stays in, and there have been several situations where if you put a big line in somebody who has OCD, what do you think they do? They rip it out. And we've had kids lose quarts of blood. Yeah. And so we will not do it. I just think the risk versus the benefit is not there. But there are some places in the country who will do it. Yeah.
Let's say at age 2 they had 2 allergies. Now at 5.5 they've got about a dozen diagnosed allergies, but then a whole host of food sensitivities like salicylates and amines and histamine, high foods. Is that a risk factor for this, or is that different?
It's different. Different. Yeah.
Didn't know if the immune system.
It doesn't seem to be an overlap of that. Yeah, we're not seeing a lot of that in this clinic. Okay. Yeah.
When back to plasmaphoresis for just a moment, when it is performed in the proper person who maybe could benefit from it, is there benefit seen when it can be safely applied to a person given?
When we talk with the groups that are doing it, we don't see much difference from IVIG. And IVIG we can give with a regular peripheral IV. And so,
but the outcome,
yeah, no different.
An abatement in there.
No, sometimes it works. So for the data, we have more data on IVIG. If you have this condition, you get IVIG about 60% of the time. The IVIG works. We don't have as much data on plasmaphoresis because it's not done as much because it's dangerous. But we think it's probably similar. We don't know. Yeah.
Do you foresee the IVIG becoming less expensive over time, or it's just the way it's...
Well, so the challenge is that it comes from human product. If there's a way to make it artificially, and there may be at some point. I mean, as far we may be able to do that, but until then, we need human donations. So donate blood. Yeah.
How would you treat with the antibiotics, and to choose the antibiotics you have to culture?
to how to pick the antibiotic. Is that what the question
Yeah,
is?
and how long do you normally treat?
Yeah. So how do you pick which antibiotic? Well, you go to your doctor and they figure out what they think the infection is. So if it's strep, we know what to treat it with, and then they will. If it's something else, so that's why we rely so much on doctors to do a full evaluation. So they culture. So we in children who have this condition, we look harder than we typically do to figure out what the etiology is. So, for example, you might take your child to the pediatrician and they've got a runny nose and a cough, and they say it's a virus, don't worry about it. And they don't do anything. And it goes away, right? In this condition, we're more likely to try to do a culture to see exactly which virus it is. So just more to help us know what this child's reacting to. So it's for that specific child.
And
So-
normally they treat it for like 10 days?
Yeah, just a regular, if you have strep throat, it's 10 days of antibiotics, you treat it just like you treat strep throat. Okay? I think the more common problem we see is that we can't figure out what the infection is. Yeah.
Can I give you a little story?
Yeah.
So my son has pandas and he's 14 and it started a year ago. So I've had a real fun year. But anyway, we found out that, I guess he's older than the normal kid on there, but there was a mold infection, there was mold in my house. And I had a really good neurologist who not only said, well, it looks like your kid has pandas, but it looks like there's also mold in your house, and I recommend you call this person and get your house inspected. And guess what? I had lots of mold in my house that I didn't know was behind both bath vanities and behind the dishwasher.
We're actually seeing that as well. Yeah.
So I just
Yeah,
wanted to share
absolutely.
that.
Thank you for sharing. So the connection with autism. We don't see a ton, but we do see a fair number, two issues. One is you have a healthy child with autism, they're making progress, they're doing quite well, moving along, and then overnight there's a change, and this is what they have. The other thing that we've seen in a few situations is the child had this condition at probably around 2. In theory, the NIMH kind of puts a bottom of age of about 3 for this condition. But we're still learning. But we have seen a couple of kids who had onset, got very sick when they were about 2, and then soon after that were diagnosed with autism. And I don't know, that is so hard to tease out. Was it just this? Were they going to have autism anyway? We really don't know. But I would say we've got 5 or 10 kids in our clinic who that's the story that we have, and we just go forward as they are now.
So it's not treatable at that point?
Well, it depends. If they're still young, and so I saw a 3-year-old where that's the story. And I saw him this weekend. We're treating him, and actually he's doing great. Yeah.
But not when they're older, like 23.
Right. So that's the challenge, is the longer you wait between onset of condition and you allow, or this continues, the inflammation, when you've got all this inflammation going on in your brain, I think the way to think of it is that you eventually are left, even as the condition burns out, with scarring. And treating with anti-inflammatories and all of this stuff is not going to cure the scarring. We do see that with neuromaturation. So as you move through adolescence, there's a burst of increased connectivity, neural connectivity, and that is an opportunity for your brain to heal. So we do see kids, and your brain continues to mature to at least your mid-20s. Some people probably till their 30s. So you have that potential for recovery, but the anti-inflammatory are probably not going to work.
So what's that treatment time frame that you're talking about? Because I chatted with you a little bit earlier with my son, and my son has progressive autism, ADHD, epilepsy, number of other comorbid conditions, and he was a very healthy child with autism, with all of these co-conditions, completely stable, doing very well progressively, and woke up with what this is described as, and has every single symptom. And I didn't put them together until you just listed them, the separation anxiety. I just thought maybe because that was something that kind of triggered just while you were going through them, is now he needs a parent to sleep with him, which he never did before, and now he does not want to be by himself at all, which is unusual, because he used to like being by himself. So those are two things that came up today that I didn't even recognize, but he's stopped eating, he's having enuresis, and he's been potty trained for years. Huge emotional up and downs all day long, all throughout. He's on anti-inflammatories. We do see that the anti-inflammatories have cut down the duration of the episodes that he's having and the frequency of them throughout the day, but it's not stopping yet. He's on antibiotics now, second round. And the first round made him so much sicker than this round has, because he still has bladder and bowel control. And so I'm trying to understand where we should go next for his treatment, because we've been kind of sent all over and no answers yet. And so, and we're almost 2 months into this, and I don't want to miss our treatment time frame. And like I said, this is all very brand new for him. He went to bed, our little angel, one day and woke up. We've been living a nightmare since then.
No, it's absolutely terrifying. So, the faster you get control of this inflammation, the more likely it is going to be cured. And so that's why, we're fairly aggressive. We move quickly. And I usually, when we start nonsteroidals, I usually ask families to wait a week or so. If they're not better, we're going to add. The next one we typically add is azithromycin. So azithromycin is an antibiotic, but we use it for its anti-inflammatory effect. And you read about azithromycin, it actually acts almost like a steroid. So we're not using it for its antibiotic effect, we're using it as an anti-inflammatory. We do those two for a couple of weeks. And then if that doesn't work, we add prednisone. So within a month, we are moving through this tiered program very quickly.
Okay.
I think in the past, when we first started this, we would wait more. But I think what we're seeing is that we need to be aggressive and move quickly. Honestly, this is a clinical condition, and we are kind of making it up. Because here in Arizona, we have the broadest program in the country. And so it's kind of frightening, actually, to be making this up. We work very closely with Stanford. We talk to them all the time. They've been doing this for longer than we have, but they're not doing as much research. So we work with them a lot. We would be very aggressive and move. Yeah.
My daughter is 31. And when you talk about shortening that time frame between, wow, something's up, to the treatment, that is so true. She had a very large number of these items on your list for a long time, and we went from place to place back in the 90s. And as you know, people are castigated and minimized and trivialized with their concerns, and that's what happened to our family. And now she's 31, underemployed, has a master's degree, underemployed, self-seclusive, OCD, limited eating, thick history of strep, mycoplasma, pneumonia. I mean, thick, back to back to back, sinus infection, HHV6, some HSV for good luck. All of this thick history from age 2 to 10, limited eating for 8 years, nothing but milk for 8 years. And then that pubertal time did happen. And she started to eat a little bit. But I think it's true, you really, she missed that boat. And I'm just curious what you tell families who might approach you, in wanting some hope from your clinic. And I've contacted your clinic, and they're beautiful people, but obviously the clinic sees only children, and that's fantastic, and I'm so glad that you all that have the opportunity to go to the clinic can do that, but people in my daughter's condition or place, in her life cannot. And I'm just wondering, what do you say to families like that?
So the behavioral interventions actually do work. So we set for CBT, ERP, all of those sorts of OCD treatments, and that's why we have a behavioral psychologist, and we have 4 psychologists in the community who we refer to get those services in place. So when we're treating kids with all of this, we are also enrolling them in the behavioral side of things, so people are doing something and learning some skills.
Do you think that's absolutely too late
No.
for my daughter to see someone about maybe an inflammatory?
I don't think it is. I don't think it's too late. I think because with the things that we start with are really low risk.
Yes.
You know, this is not, you know, chemotherapy.
Right.
You know, a leave you can buy over the counter. So our initial pass is.
I will say that my daughter at age 17, we brought her to the AIMA clinic in California and had some SPECT scans done on the advice of another parent. And her basal ganglia were like inflamed.
Wow.
With this excessive blood flow, along with multiple other areas of her brain, as well as many underperfused areas of her brain. So that was age 17. 7 years later, at age 24, a repeat scan was done. And to our shock and dismay, the basal ganglia were worse.
Really?
And so was the significant asymmetry between the overperfused, the underperfused, all except for one small area, I think, were worse in 7 years, and it was obviously the same brain. It wasn't like, oh, someone got them mixed up, or different clinic, different time, different tracer, or whatever. So these were the same conditions, and the same brain came up worse significantly without, you didn't even need a brain scientist to see this.
So I guess the question would be, is that ongoing inflammation, or was her brain changed by the inflammation and now it works differently? So, and I don't know that there will be an answer to that.
Right.
Yeah.
Right.
Yeah, go ahead.
I have another question. So you went through the evidence-based protocol for treatment, anti-inflammatories, antibiotics, steroids, and IVIG. At what point and like what duration would you trial antibiotics for? Do you go through a couple of different types? Do you go for a week, 10 days, 14 days, a couple of months, a year, before you move through that process?
Yeah. So it depends on what we're treating. If we have an infection, we just treat the infection. And so that might just be 10 days if it's strep throat. If we're treating with azithromycin to use it as an anti-inflammatory, we typically do it for a month.
That's another question.
And then what we do is we wait until we can get hopefully things under control. Life is better. And if it doesn't get better, we keep going.
Okay.
Okay? So, and if it does get better, we then try to back off. We will, if they're doing great on a combination of Aleve and azithromycin, we give that for a couple of months, and then we stop one of them. And then we wait a month, and usually families have a preference. So we would like to stop the azithromycin, but sometimes families don't want to, and I know. And so we'll stop one, and then wait a month or so, and if they do okay, we'll stop the other one. And then what will likely happen is that they're going to get another infection, and they're going to flare, and this is going to come back. But then we have our toolkit. And so most families have a cabinet, and we will give them an extra round of, and the way we use azithromycin is, it's a very, very long-acting medication. So if you've ever done a Z-Pack, you only take it for 5 days, but it lasts in your system for 10. So we use azithromycin only Monday, Wednesday, Friday. We don't need to use it every day. And so we give families a Monday, Wednesday, Friday month. We give them a burst of steroids and ask them to go buy some Aleve or ibuprofen, and you keep that in your cabinet, and if you start to see a flare or somebody starts to get sick, you start it right then. So we're managing.
A little bit more proactive.
Yeah, we're much more proactive.
So then do you expect that these little flares will keep coming up anytime they get exposed to it?
Yes.
So this was my next question then. So my son has been positive for strep with swab and a culture 5 times since August 25th. And
this August?
Since
this
August.
Wow.
And he's been negative after treatments, but then our pediatrician that we see was unsure if he could be a potential carrier, and she said that she recognized that he is in pandas because he's got all the textbook symptoms that came from, appeared one day out of the blue.
Yep.
And he is positive every time with strep.
Yep.
So she was uncertain if he would be a potential candidate to have his tonsils removed because he's not ever been positive before ever. So 5 times since just not even 2 months ago. So she was saying maybe I need to see, she put in a referral for us to see another immunologist. But we have an ENT that we work with who took out adenoids and put tubes last year, but left the tonsils because he said they didn't look problematic.
Yep.
So she was wondering if he is a potential carrier, do we need to remove those? And if we remove them, will he still continue to get positive for strep in the future?
Right. So, great question. So, when you go to an ENT who is not familiar with this condition, their criteria, I think, are 7 strep infections in a year.
Oh, wow.
Or they won't. You're good. You're on that path. Or they won't take them out because insurance. That's the literature, and insurance won't pay for it.
Okay.
However, there's a couple of ENTs in the country who have been very interested in this condition, and they've taken out the tonsils and they've sent them to pathology to look at, and typically what they see is micro abscesses deep in the tonsils where it's likely that the antibiotics aren't getting there. And so absolutely, I think your pediatrician's on the right path.
Okay.
Would that be Dr. Joy Goodman?
No.
No.
I will think of his name in a minute, but yeah.
So I'm noticing a lot of symptoms on all these different lists that are familiar to my son, but he's 15, so could have happened earlier. But I've talked about this with my doctor before, and I don't think he has the OCD component, but perhaps my definition of OCD is too narrow. So can you maybe discuss some of the lesser known
what is OCD
symptoms?
Yeah. So what is OCD? So you break it down into obsessions and compulsions, and the challenge with this is if you have autism, that's a huge overlap. So I think that within autism, the OCD piece is often harder to tease out. But obsessions are thoughts that you can't get out of your head, and in general they are fear that they're going to be injured, or that somebody they love is going to be injured, or that they might injure somebody else. A thought that we call it symmetry, that things need to be a certain way. Of course, if you have autism, that might be just your baseline. Cleanliness, fear of contamination. And then the other obsession that often is very hard to get out of children is taboo subjects and religiosity. So sexual ideas or thoughts become very, very religious, or have ideas, different ideas about religion that may be different than your family. So that's the obsessive. Those are thoughts. The compulsion is the need to do something. So, and we think of this as basically 4 areas: harm, symmetry, cleanliness and contamination, and then taboo thoughts. And so within that, with compulsions, with harm, there's actually, we see kids who, they want, usually the parents don't let them, to sleep with a knife because they're going to save their family. They're sure that they're going to be injured or somebody else is going to be injured. Cleanliness, they come in with bloody hands, just having to wash their hands so many times. The example that I gave of the girl who had to burn her clothes, that's a compulsion to burn things after they've been touched. And then religious or sexual thoughts, they'll just need to be going to whatever service all the time. They're compulsively reading about whatever it is. So those are the areas. It can be very hard to tease out with autism.
Can I suggest it's possible that the obsessive part can maybe change, maybe from hyper-religiosity in a 2 or 3 year period over to a food obsessive thing, and then to something
Oh,
else?
absolutely. And we see that not even just a couple of years, we see that obsessions and compulsions, the character, how you present having OCD. So I get less when I'm taking a history, I get where they are now, but yes, you have it. And if I see you a month from now, your obsessions or compulsions may be different.
Can you get the diagnosis without that OCD component, or it's just, no?
No.
So it's just
It's-
something
it's-
else?
It's part of the
Different
diagnosis.
medical mystery.
It's a part of the, yeah. Well, so that's an interesting thing.
Because he
don't wanna be flippant.
knocks like everything
Yeah.
but that OCD.
So, and again, I don't want to tell you something that may change in 6 months as we learn more. But right now in our clinic, what we're doing is we see families, children, and if they very clearly overnight, they meet this criteria, we in our group, we call that's a 1. If they come and they've had these just OCD or behavior issues, or we see a lot of families coming just with kids with behavior problems, but they don't have acute onset, they don't have a lot of the other stuff, that's a 3, and we say we don't need to see you anymore, go back to wherever it is that you're seeing. The 2 group for us is the most challenging, and your son could be the 2 maybe, which is they have some of it, and we think they have something going on with their immune system, but it doesn't fit either category. And that's a group where we used, I would say a year ago, we were doing 1s and 3s, and now we're starting to focus on that 2 group more, and we're doing a lot more medical evaluations. We do a lot of MRIs, EEGs, lumbar punctures, all kinds of things to try to figure out where the inflammation is and what might be triggering it.
Are there
Yeah.
markers of inflammation in an adult that you could also use in a child to help figure this out?
We do.
C-reactive protein.
Yes, we do SED rates, C-reactive protein, we actually do that. We do ANA antibodies, so if you have lupus, that's or arthritis, we look at all of those same markers. That's part of our lab panel. Okay, let's go to the next one. Okay, IVIG, I think I've talked a lot about this. This is the problem, and it's, we can't synthesize it yet. I would think with, as genetics move forward, that eventually we might be able to do that, but right now, it's really, really expensive because it's a blood product. Many thousands of donors per infusion. It is also hard to administer, and we have had some children who we don't think it's actually safe to give it to them because you have to sit still and leave an IV in for 4 to 6 hours, and 2 days in a row. There's a lot of kids who can't handle that. So we have had some children who get to that point, and we just manage with all of the other medications just because we don't think it's safe to do that.
A symptom you didn't mention, and maybe it does not apply, but since we're talking about needles and holding still, is a reduced pain acknowledgement or a heightened pain, threshold, like very heightened. Would that be part of what we're talking about here, and it just was omitted, or it's not relevant?
I don't think it's has been seen consistently, so it didn't get into the diagnostic criteria.
But you do see it?
I don't know.
Yes, it's more the sensory stuff.
Okay.
But we don't, not as much.
Okay.
Yeah, not as much.
One more thing.
Yeah.
So if this has caused sort of overnight in a young child autistic presentation, do you still treat that kind of autism the same?
So a child has autism and then overnight, no, they didn't have autism.
So they didn't have autism,
Okay.
but they regress, and then it presents like autism?
Yes,
And they get diagnosed as autism and they go to an autism school?
yes.
Is that the right treatment?
Well, it's one arm of the treatment. So we would treat behaviorally, that's why we have a BCBA-D in our clinic, and he does everything a BCBA does, and makes recommendations for ABA in schools and all of that. So absolutely we do that, but in addition, we're also treating biological, the medical things. Yeah, we do both.
Okay, so my question is, the ship's already sailed for my son, but the things that you've brought to light are exactly what he did at 19 months.
Yeah.
Okay,
Yeah.
so he's 23 now.
Yeah.
So what? I mean, treatments are not. things that typically would have been well received by most people on the spectrum just either don't work or kind of a hit and miss kind of thing for him. So what should we be doing with information like this to be able to improve his outcomes? I guess is the best way to say it.
So you're saying like ABA doesn't work? Is that?
Well, it is hit and miss. It
Okay.
minimally works. I mean, we've seen some improvements, but it's kind of.
So we have found that, so we have this BCBA-D, but what he is doing is often helping parents manage the behaviors at home. We've seen more improvement with the very OCD-specific therapies rather than ABA. So that's what I would do, is cognitive behavioral therapy, exposure response, training, those kinds of things.
Okay.
Okay, let's go to the next one. So these are the people on our team right now. We're in Tucson. We are trying to get an alternative medicine person to join us, just because I think it would be really helpful, and a rheumatologist. We've seen, this is not a guess, we did this a couple of months ago, 400 patients from 30 states. We have people flying in from all over the country. And I guess stopping there, I'm sorry for what you guys have been through. What we do see, the other thing that we are doing is doing things like this. Two of my colleagues, the immunologist and the psychiatrist, are in Dallas today, giving similar presentations. And we've spoken twice to school nurse, the big statewide school nurse group. We are trying to get it, we've done a couple of emergency department because we find that children are not treated nicely with this condition in the emergency department because again, families are kind of poo-pooed that you don't know what you're talking about, take your child home. Yeah.
Is there a comorbidity with metabolic or mitochondrial disorders?
It's an interesting, there may be, and I think that maybe in that 2 group where, I think that's where we're trying to go.
My daughter would have fallen.
Yeah, so that's where we're trying to go and so in that 2 group, we're doing all of these tests, and we're doing genetic testing and looking for mitochondrial disorders and everything. We're starting to look harder in the 2s.
And why rheumatology? Can you talk about that a little bit?
Yeah, because it's similar. It's an autoimmune condition, arthritis, lupus, all of those things.
Inflammation.
Inflammation. It's an inflammatory related subspecialty.
I've heard of lupus, neuropsychiatric cerebritis.
Correct. Yes. And so all of these things, these are autoimmune conditions that we respect clinically in the medical world when they affect your body. I'm just not quite sure why we don't respect them when they affect your brain.
Amazing.
Yeah.
You had started to mention the treatment by professionals in the ER.
Yeah.
What would a family, why would they go to the ER? Like what would, even if the people at the ER were welcoming and well aware of this, what is it you would go there for anyway? What would they do?
That they're not safe at home. They're gonna.
But what are you?
So what we'd like the ER to do is to take that history and recognize that this is a condition that we would like them to treat with antibiotics. We would like them to start anti-inflammatories.
Right, in the ER?
Absolutely. We're asking school nurses to do it. We're all over the state right now. What we would like is that our clinic can go away. That this is treated in EDs by pediatricians, and that this whole huge team is not necessary. This is an easy thing. This first pass is very easy to treat. So there's no reason that any doctor out there can't do this. The only thing you might need us for is IVIG. But anybody can do this.
Yeah. So then, my thought now is should my pediatrician that is treating him right now until we can get back into our neurologist who kind of specializes more so in this condition, should she move my son along to steroids if the antibiotics don't work?
She absolutely could. We find that a lot of pediatricians, they're a little nervous after you get beyond the first two. And when we start talking about steroids, they're like, well, that might make it worse. They don't know. And I probably take 5 or 6 phone calls a day.
Do you see a lot of pediatric psychosis? Because that's what we were, prednisone was mentioned, and our son, while he's had this condition going on, has been exceptionally aggressive towards himself and towards others, and he's never been an aggressive person. But while this is going on, he looks like he's on fire, essentially, and whoever kind of comes around him gets the flailing, the hits, whatever is happening that he's kind of doing to himself by just trying to engulf him and kind of keep him safe. And so prednisones had come up as a potential treatment, but we were told that it wouldn't be a safe option for him because it could put him into pediatric psychosis.
We haven't seen that.
Yeah, and so I honestly had never heard of that.
Clinic.
Excuse me?
You need to go to her clinic.
That's right. Exactly.
Oh, yeah.
So, we haven't seen that. We do see that, there's a mix. Some kids get better right away with the prednisone. Some kids are really uncomfortable and don't feel very good for a couple of days. But it would be the same way that you would feel if you took it for asthma.
Okay. And so if they're responsive to steroids, would you just keep them on long term, or would you? Okay.
We would do a 5-day burst. Or, and as I said before, if they're the group that they respond to steroids, but when you stop steroids, they get worse again, then we would taper. Okay. So, but in general, most of the kids we've seen 5 days, you're good.
What kind of dose are you talking about for this?
1 to 2 milligrams per kilo. So it's what most pediatricians would do for asthma.
Okay.
Yeah, we've seen kids. So kids from a lot of different states. This week I saw 3 kids. So we're also very slow. We see 5. There's all of those doctors, and we only see 5 kids. So it's very intense. It takes a very long time. And I saw somebody from Minnesota, Ohio, and Georgia.
Is it private pay?
No, we take insurance.
And what's too old?
18.
Okay.
On that note, is there a short list that you might be willing to reveal about where someone who still wanted to give it a go could take someone who's over 18?
That's a great question. We're struggling with that.
There's
because
1, 2, possibly 3.
Yeah.
Here.
Yeah.
I'm just saying.
Yeah. I probably would go to an immune person, whoever it is, an immunologist or a rheumatologist.
Okay.
And then, and you might have to do some education for them. And we are always welcome to talk. Our immunologist, Mike Daines, is he's training kids and adults. So he's probably the one that the rheumatologist or immunologist want to speak with, because they can talk adult language better than I can.
Daines, D-A-N-S?
D-A-I-N-S. Yes, I'll show you. Let's go to the next one. I want to wrap this up. So expansion, we now have a satellite clinic at Carden, Big Banner Carden. That clinic doesn't have this big team. It has a general pediatrician and a nurse practitioner. And the more complicated kids, they send to us. We are working with University of Wisconsin, Virginia Commonwealth University, and Emory to develop teams just like ours in all of those places.
So one of our families in this community had definitely the sudden onset pretty recently, and they went to Cardon Children's, and I just thought I'd share with you, the ER doctor said the problem is all the parents now think that their kid has this and they really don't. It's like everybody's got the idea that this is what their child has, where I don't think that's true. I mean, look how...
No, it's not. Because as I said, we in our clinic, I don't know if you were here, we were saying we have the group where we say, absolutely, this is what you have. The middle group that says, we think you have something, but it's not as clear. And then the third group where, no, this is not what you have. And we are very direct with people to tell you which group we think you're in. I think in the ED, it's hard because they get all comers. And if you go to the next one, I think.
I would follow your gut. I've been vindicated more often than not by a
Well,
large
and
margin.
my thing really is that our initial interventions are very low risk. We're not doing surgery, we're not doing anything we're not doing anything very fancy, and it's a very easy thing to do. This is where our research is. Everybody who comes in, we ask them to enroll in our registry. We're looking at an IVIG trial because we need to get data showing that the IVIG works so that we don't battle with insurance companies as much. So we're working, this is going to be a across the country kind of project where we're collaborating with the NIMH and all these different sites to, we need to talk with each other so that we learn from each other. And as I said, I may have said something here today that I will tell you is different in 6 months because we're learning so much so quickly. We are looking at biomarkers and genotyping, so we're doing tons of genetic testing. And then we have, there is a germ-free mouse. And we are, have a lab working they just arrived this week, the germ-free mice. I am on my way to Flagstaff. We have a family in Flagstaff who, their child has this. I am going to go collect poop. And we are going to bring it back and give it to these mice. And so it's a microbiome, kind of looking at the microbiome in the condition. Yeah, I have an ice chest in my car on the way to Flagstaff. Okay.
You had to go all the way to Flagstaff to
Well,
find
so
something?
the challenge is we tried to get it shipped. To get a courier, it would cost us $600, and they actually shipped it to us, and it didn't arrive very nicely.
But aren't there kids just in Tucson that?
Not some, there's a particular subgroup that we're looking at.
Okay.
And that's why I gotta go to Flagstaff. Yeah. So how did this start? We actually, a grandfather here in Phoenix approached us a couple of years ago and said, and his son is now in his 20s, but he said, our family has been through this, and somebody has to fix this, and we did. So we went, my co-director and I'll show you the names in a second. We went to the NIMH. We were calling all over for 6 months trying to learn as much as we could. And we started seeing patients in May 2016. Next. So this is, Mike and I, this is your immunologist, Danes. That's, if you're calling for an adult, you want him because the rest of us are really pediatric. We worked together in a clinic trying to sort this out. Next. And then we added all these people. And then, go to the next one. This is our team now. And we're trying to add several more. And then these are the two in Mesa. Okay, next. So we do, as I said, education, not referral. This is not a hard thing to treat if you catch it early. And so we're trying to get all of these people to do it, and so that we're not necessary. I would like to be out of a job.
Our daughter at 31, like I said earlier, has a master's in science, actually in nutrition. But she also racked up $70,000 in student debt. So for her to be underemployed, if we could help her pinch off a little more in the ability department, she would have a higher chance of being able to repay that student debt.
Yeah.
So there's a lot of, going on that people with children under 18 may not fully understand, but in our experience, this doesn't really go anywhere. It just sort of shifts and changes as the person ages.
Yeah, and I think recognition. I started seeing and diagnosing children with autism in the 90s, and at that point I spent a lot of time explaining what autism was. Well, everybody knows what autism is now, but I think we've missed generations of adults, and I think that this is a similar thing in this condition. Many years ago, in the early 90s, the families who I saw were very high socioeconomic status, very educated, and they came in looking. And now, of course, autism, it's in the community. What I see in this condition now is very high socioeconomic status, very well educated people. We had a family come in this couple weeks ago. Dad is a Hollywood producer. They flew in on their private jet and arrived in Lindsay. So it's a different population. Our Arizona population is not, but the people who are coming from other states, it's a different group. I think this is it. Yeah, that's it. That was good, huh?
Yeah.
One time.
I had actually looked at this topic
Yeah.
for years prior to today.
Yeah.
And every year or two, I would relook to see if I could find anything more. Susan Sweeto's
Yeah.
investigation and writings on the topic, and nothing was available coming out of her
Yeah.
work until like 3 months ago, and I realized her clinic was here, because I looked again.
Yeah, no, Sue's the one who has been mentoring us the last couple of
That's
years.
what I figured.
Yeah.
Yeah, so all this time, nothing for the consumer or patient family, all these years, since like '04. So
Well,
I've
so
been looking
the
since '04.
consensus for the diagnosis was put together by the group. We didn't participate in that, but it was led by Stanford and Georgetown. And that consensus paper came out, I think, in 2015.
15? Still, that's not that long ago.
Not that long ago.
Right.
Yeah.
I'm surprised somebody would make it to your clinic or anywhere with this when there was a shortage of information other than Susan Sweeto, which appeared to be being done in someone's basement or, some small place. That there was no energy for, consumers and patients and children and like that.
Yeah, Stanford's clinic, they will only see children who live within 30 miles of Stanford. So we see families who live 35 miles away from Stanford.
There we go. Is this all that you're doing currently, or do you still see
Oh, no.
other patients?
Oh, no.
Okay.
I see, I see.
You came up
my-
on our insurance, and I was like...
No, my day job is autism.
Okay.
This is my night job.
Oh, okay. And do you have an office up here? Because Cynthia's like, why did she come up? She's far away from me.
Yeah, no, I know I'm in Tucson.
Okay.
Yeah.
So do you think that Dr. Daines would be willing to entertain a conversation with a parent of a 31-year-old in order to help find an immunologist who may see, or rheumatologist who may see a
He would
31-year-old?
probably prefer to, we all have our personalities.
Sure.
He would probably prefer to speak with the doctor. The immunologist that the Cardin group uses is Dr. Casper.
Oh, Dr. Casper. My daughter has an appointment with Dr. Middle.
He's pediatric, right?
Yeah,
Adult
but
too.
Dr.
Adult too.
Helmers sees adults, and he's familiar with Candace. And he's Helmers?
Helmers.
Yeah, he's
Robert
actually
Helmers.
spoken at our conferences too.
So I was referred to Dr. Casper and Middle in the same practice. And it was said that maybe Dr. Casper more than Middle, but because of insurance.
So in general, immunologists are trained in both adult and child.
Oh,
And then
yeah.
you decide what you're going to do.
They-
So Dr.
they see
Daines
both.
could actually see adults all the time. We just won't let him because the
Right.
rest of us can't.
Right, but he would prefer to hear from who? I'm a little bit confused. He would prefer to hear from
The doctor.
the doctor.
Yeah,
Dr.
he
who?
would, whichever doctor you choose. So if your daughter sees Dr. Casper, he does an evaluation, and then Dr. Daines, the two doctors would speak.
So if Dr. Middle saw my daughter,
Uh-huh.
then those
Have
two
him
would
call
speak.
Mike.
I see.
Yep.
Okay, thank you.
Yep. Okay. Thank you.
Thank you very much.